Everybody, here is Dr. Kelly Hill, the moderator for today's panel. Thank you.
All right, good evening, everyone. It's really nice to see everyone here this evening for this program. First, I want to welcome everyone to this UDC Workforce Development and Lifelong Learning and Wards7&8 DC Prevention Center inaugural week-long opioid prevention strategies virtual workshops. I even remember the time when we started talking about these events, having them with the Workforce Development campus, and seeing it now come to fruition basically as this week-long event. Today's theme is a Wraparound Wednesday, No Judgment, Finding Support for Treatment and Recovery. This is funded through a grant from the DC Department of Behavioral Health, Live Long DC Opioid Awareness Campaign. You all can find the presenters' bios on the online website, UDC's website. Okay, so I wonder how many of you all, and you all can do this in the chat, or you all can, just kind of nod your head yes. How many of you know about DC's opioid epidemic? Thumbs up or put it in the chat. Okay, I see some. Cool. Let me see the chat. All right. Definitely. Some people say definitely. All right. So I can see that we have a pretty good number of folks who know about the opioid epidemic in DC. So you're going to learn about ways to support someone experiencing opioid use disorder and what resources are available at UDC this evening and the community as a whole, as well as how to access them. Our presenters are well equipped with some of these resources and support systems for you all in the community and UDC. So some of the housekeeping rules that we have, just so that we can keep this going smooth as possible. We're using our Zoom etiquette. Please mute your mics when not talking. You may use the hand icon to be recognized and speak during such time. All right, so you guys can practice if you need to. Make sure you put your hands down when you do not need to speak. All right. We'll use the chat box to provide information, and you may use it to make comments or ask questions. The chat file will be saved for later use, and you all can see that this video is being recorded, so you all can access it later as well. So make sure that you all use that proper, I call it netiquette or Zoom etiquette during this time. And make sure that you view the link later on. So at the end of this discussion, there will be an exit survey link in the chat box. Please make sure that you take the time to complete it so that we can get your input on how this program went. All right, so once again, I am Dr. Kelly Hill, Assistant Professor of Psychology at UDC. That is the psychology program. We are still working virtually through this global pandemic. So I'm very ready for this program and moderating the event virtually. All right. So first I want to recognize the partners of this event and see if they want to share any welcoming words. So first we want to make sure that we include Dean Smith. Is Dean Smith here this evening from the Workforce Development and Lifelong Learning Campus?
She's not online as of yet, Dr. Hill.
Okay. All right, so we can come back to Dean Smith. We also have Rosalind Parker, Director of DC Prevention Center and President, CEO of BRIC Incorporated. Would you like to say some words, Roz?
Okay, good evening. Thank you everybody for joining us. This has been a very productive experience, and Dr. Hill, it's wonderful to have you back with us, and looking forward to another productive session. Thank you so much.
Great, thank you, Roz, for that. And just to say, would anybody else from the Prevention Center like to say a word? Nora, would you like to say anything as well?
I would like to thank everybody for getting on. I hope you gain a lot of information. We have some extraordinary presenters on, and they are a wealth of resource. So please tap in.
And I also want to thank everyone also. This is Stephen Hazel. Thank y'all for being here. Appreciate y'all.
Great, thank you all. All right, so thank you again for joining us this evening. We have a wonderful program today. Our theme again is Wraparound Service Wednesdays, No Judgment Zone, finding support for treatment and recovery. So I want to recognize our distinguished panelists. First, we have Dr. Edwin Chapman, world-renowned physician and treatment provider for opioid use disorders. And I had the pleasure of meeting Dr. Chapman back when we were actually doing those interviews that you saw in the video, and having the kids interview some of those participants or patients of Dr. Chapman as well. So I've had the pleasure of talking with him and him being able to speak about the opioid epidemic as well. The next panelist that we will have is Mark Robinson, and you all can raise your hand as I'm saying this as well if you like to. Manager for harm reduction at Family and Medical Counseling Services. Had the pleasure of meeting him at maybe a couple of meetings as well. So welcome this evening as a panelist. And then we have Anna Jones, Resource Coordinator for Oxford Houses. Oh, we don't have Anna? I just read that. Okay, no, she won't be able to join us this evening. Sorry about that. So let's begin with our first speaker, Dr. Chapman. So Dr. Chapman, you can start sharing your slides with us if you'd like to.
Are you able to see my screen?
Yes.
And thank you so much for inviting me. This is such an important program, and it's so well put together. I looked at the videos that you showed initially, and so a lot of what I'm going to go over will just reinforce those points. I'm going to move very quickly because I know that time is of the essence. And I want to start with what we know. So if we go back to the late 1990s, we were at a point where Europe was as well. So Portugal and France, for example, had the same problem we had, but they took a different course. They treated their opioid problem as a medical problem. We continue to treat our opioid problem and substance abuse problem as a criminal justice problem. So this slide simply shows, if you look at Portugal and France today, they have about 6 or 7 overdose deaths per 100,000. And I think ours are even higher now, with the United States down here with 312. And this was a slide from really several years ago. We can also see that there was a dramatic drop in HIV infections in Portugal, corresponding to the treatment from the year 2000 to 2015. So that should tell us something. When we look at the next slide in France, they had, again, in about 1999, they started using medication for opioid use disorder, and they saw a dramatic drop in overdose deaths. If you look at the red line, the green bars show the increase in the use of medication-assisted treatment. So there's a definite correlation with treatment. This slide again shows the dramatic change in criminal behavior. The blue lines or blue bars show 6 different sites in in one of these countries where they measured crime. But with medication-assisted treatment, if you look on the right-hand side, the black bars show a dramatic decrease in crime. So France predominantly used buprenorphine, which is one of the 3 medications that we currently use. Portugal used methadone, but they got the same results. So the 3 medications that we use, and I'm sure you've been over this in some of your other sessions, are methadone, which has been around about 60 years, started by a really became very popular in this country in the 1960s by doctors Dole and Niswander, and also a Black physician, Dr. Melissa Freeman, who actually graduated from Howard University Medical School in 1955 and was the first person to treat a woman to term using methadone. She is now 95 years old. She still practices in New York, and she still runs her methadone clinic. So if you want to talk about stigma and somebody who can destigmatize the use of medication, you should meet this wonderful icon who, as far as I know, has the world record for methadone treatment. She is 95 years old. So I'm not going to go through all the details of methadone, buprenorphine, and naltrexone, which is the 3rd medication. But just briefly, methadone is what we call a full agonist. So it does everything that morphine and heroin will do. It can depress your respirations and cause you to stop breathing. It's usually prescribed in a clinic setting that's heavily regulated. Buprenorphine, on the other hand, is what we call a partial agonist. It has what we call a ceiling effect, so that even if you give more of the medication, it will not likely to depress respirations or cause the patient to get high if taken correctly. And it can be prescribed in an office-based setting in the privacy of your private physician with a prescription. Naltrexone is what we call an antagonist, and all 3 of these medications bind to the so-called mu receptors in the nervous system, and they block the ability of these other drugs, heroin, fentanyl, to attach to these receptors and do the damage that they do. So again, we know the history of in our community. Our folks were locked up for the past 60 years, and not only for heroin, but also for cocaine and any other drugs. So the opioid crisis in the Black community, when we talk about the opioid crisis, we know that we've had a problem for 60 years. This is nothing new. It only became fashionable when it hit the suburbs and rural areas. So when we look at what we're really dealing with a conundrum where we have a group of patients who are silent due to shame. And they also, as the speakers have said in your videos, many times suffer from mental health problems. So they don't speak up for themselves. They don't defend themselves. And they are thrust into an incentivized prison industrial complex. Media bias, even today, our patients don't get the kind of coverage that you get in the suburbs. Our faith community, our families, and even our medical providers stigmatize this patient population. And I'm going to admit, when I was in medical school, beginning almost 50 years ago, that these were the last patients you wanted to see, because we felt that this was a moral problem. So when we look at this, we have to, what I call, reverse engineer all of that bad science that we've been taught for the past 60 years. And these are some of the barriers that we have to overcome. Buprenorphine and some of the medications that we use require prior authorizations, meaning that even though the doctor prescribed it, you have to go to the insurance company to get authority to use it. We had limitations. You had to have a special license to prescribe buprenorphine. And for methadone, you have to be in a special clinic setting. We lack integrated or sharing information in our healthcare system. We have inadequate workforce and workforce training. You know about stigma. The methadone clinics and buprenorphine providers are paid about 1/3 to 1/2 of what it really costs to take care of these patients. There's same-day billing restrictions, so you can't do a primary care visit and a mental health visit on the same day, which is a logistical or structural problem. And then there are limitations on harm reduction services. And of course, we talked about the incarceration conundrum. So I'm an internist, meaning that I usually treat high blood pressure, diabetes, arthritis. But I was invited back to my alma mater, Howard University, about 8 years ago, because they recognized this problem. And we formed an organization called the Urban Health Initiative, addressing the opioid problem and the impact on the entire family and the community. And this is the original group that initiated that. If you're familiar with Dr. William Lawson, he was chair of psychiatry at Howard at the time, and several of the members are still there. The problem with our healthcare system is it's in silos. So drug treatment is one place, mental health treatment is someplace else, and primary care treatment is in a different location. So what we recognized was that we have to integrate these disciplines. They need to be in the same place or have access to the same information so that the patients are really getting what we call patient-centered care. And we can see from this slide, if you look at the blue bars on each one of these chronic diseases and the red bar on the right-hand side, you can see that if a patient has no mental health or substance abuse problem, the costs are much lower. But if they have both a mental health and a substance abuse problem, the cost of any chronic disease quadruples. And that kind of makes sense because the head dictates the body. If you have a mental health problem or a substance abuse problem, you're not going to take your blood pressure medicine or your diabetes medicine the way you're supposed to take it. So patients frequently would end up in the emergency room with a hypertensive or diabetic crisis when really the underlying problem was a mental health or substance abuse problem. So we did a survey at Howard and we found from the outset that 42% of our patients needed additional mental health services. We also, and this is just a slide showing the Black Mental Health Alliance, which is one of the major groups in Baltimore, and they do a lot of online mental health services, and you can go to their website. But these are some of the best psychiatrists and psychologists and social workers in the country. Unfortunately, on the right-hand side, Dr. Patricia Newman, who worked very diligently with us and is a pioneer in psychiatry, passed away last year, but we're working to keep her work going. We also want to emphasize the importance of the so-called social determinants of health. Where you live is extremely important. Being homeless and then placed in housing is actually medical treatment. So I consider housing medicine. And we can see that the cost of any health situation goes down when a person is in safe housing. So this is what we're faced with, the so-called prison industrial complex as defined by Michelle Alexander in the new Jim Crow. Our patients were incarcerated, and when they're incarcerated, their chance of getting infectious diseases. Of course, they lose their job, homelessness, et cetera, goes up. So if addiction is a disease, why is incarceration treatment? That's the first question. And we now know that if one is incarcerated and discharged without being, especially for opioid addiction, without being placed on a medication, you can see the black bar with the arrow that within 2 weeks, you have the highest overdose death rate because those patients will come out, their tolerance is down, they go back to the neighborhood, use the same drugs that they were using before, and overdose and die. So this simply shows a schematic of so-called reverse engineering, where instead of putting somebody in jail, that we send them to treatment. That's what this is all about. I was on a panel with this doctor, Josiah Rich, from Rhode Island, and they did a study, again, showing that by placing patients on medication, when they're incarcerated and discharging those patients, the overdose death rate decreased by 60%. The same applies to a person who overdoses and goes to the emergency room. That if they're not placed on medication in the emergency room, the chances of them coming out, overdosing, and dying is increased. So Yale did a study about 7 years ago, again demonstrating that if a person is put on medication starting in the emergency room, that they have an 80% chance of following up in 1 week, as opposed to a person who's discharged with a paper referral. There's only a 30% chance that they will follow up. So buprenorphine is now the standard of care for an overdose in the emergency room. But again, unfortunately, in our community, buprenorphine was not taken up the way it should have been 20 years ago when it was first approved to be utilized. Most of our patients are sent to methadone clinics with tight restrictions on treatment. So today, only 2.7% of Black patients across the country receive buprenorphine, even though we have the same percentage of drug use as other communities. And as a matter of fact, between 2018 and 2019, study just came out from the National Institute of Drug Abuse and NIH, showing that overdoses leveled off in the white communities, but increased by 40% in African-American communities across the country. So how do we fix this? We fix this by doing what you're doing. And we call this the cycle of repair. And the first step is education. And that education has to start with medical and non-medical professionals, because this is a community disease, just as COVID is a community disease. Meaning, I didn't say communicable, I said community disease, meaning that it impacts all of us through criminal activity, through infectious diseases, through families that are destroyed, homelessness, et cetera. So we have to, the treatment has to be as a community, and there's a role for everybody. So, and it starts with education and advocacy. Then you have to have a medical community that's in tune to treatment, and you have to have enough providers, and those providers go beyond just the doctor prescribing medication. You need social workers, psychologists, and what we call peer navigators in our community, are people who've had lived experience to help these patients walk through this complicated system. And we also use the faith community and community organizations that can help with housing, food, clothing, and transportation. So all of this fits into this schema of the cycle of repair. And I'm sure you've talked about Narcan as the first chance or second chance recovery. We can't treat a patient that's dead. So we have to have a live patient. And now we're using Narcan, and anybody can resuscitate a person with Narcan. You can't do any harm. We talk about needle exchange and other forms of treatment before patients actually get on medication. So we need all of these services. Needle exchange reduces the spread of infections, even though the patient may continue to be using. But that contact, that trust may move that patient on to the next step. You'll hear a lot about safe injection sites. Again, they're not utilized in this country, but in Europe, they've had reportedly no deaths. And this is where medical personnel are available. But again, it's meeting the patient where the patient currently is. They may not be ready to stop, but at least by getting that trust factor, you may be able to move them on into treatment. We know that residential treatment and incarceration without medication is lethal for the reasons that I showed above. And again, the treatment of choice is medication assisted treatment, methadone, buprenorphine, or Vivitrol. So this is Reverend Dr. Frank Tucker, who has worked with me for almost 20 years on community health activities. And he formed the Leadership Council for Healthy Communities, which is a faith organization, interfaith organization in the metropolitan area that includes multiple churches. He was able, before COVID, to bring medical providers, psychiatrists, and you'll see Dr. Newton before she passed, Dr. William Lawson that I mentioned before, Dr. Ivan Walks, who was the former Commissioner of Health, Ambassador Susan Johnson, who worked under the Obama administration, all in one room to talk about mental health in our communities. This was before COVID. We recognized that our community was under stress. So this is just a schema showing the geographic distribution of the churches. But about 2 years ago, the District of Columbia put out grants to 40 churches to really educate the community on the opioid epidemic. And these are some of the types of programs on the right-hand side that we put on, including naloxone training. And we've used Zoom to continue those educational programs. So this is a schema of my office practice. Again, I'm an internist and I do substance abuse treatment, but I'm not a psychiatrist. So 7 years ago, while at Howard, we set up this unique approach using telehealth. So we were 7 years ahead of the curve in getting ready for COVID. Didn't know COVID was coming, but knew that telehealth was a valuable tool, even in an urban setting. Telehealth had been used in rural settings, and a lot of people did not think it was apropos for an urban setting. Now you can't do without it. And this simply shows how we coalesce all of the disciplines that I showed above: primary care, mental health, peer coaching, and social worker into a telehealth project. That means that when a patient comes in my office, we can connect them with a social worker, psychiatrist, or psychologist, or peer coach using telehealth without moving the patient. We can provide multiple services on one visit. So when we look at what works and what does not work, There's still a divide in the medical community and the treatment community, abstinence versus medication-assisted treatment. There's still people who will tell you that medication-assisted treatment is just replacing one drug with another. That is not true. And this shows schematically from worst to best the treatment modalities. And we now know that medication-assisted treatment combined with integrated primary care and integrated psychiatric and psychology is the best treatment for our patient population. So how can we help our patients? If you look at the yellow bars across the top, there are multiple times that these patients intersect with the community and can actually be helped. But we have many instances where we have missed opportunities. So person overdoses on the street, gets up and walks away. We get no information from that patient. That's a missed opportunity. Patient goes to the emergency room, discharged without being placed on medication, without follow-up, missed opportunity. Placed in the criminal justice system and not put on medication while incarcerated, missed opportunity. Residential treatment without medication, missed opportunity. And of course, if a patient tells someone that they have an opioid problem and they're not directed to treatment, again, that's a missed opportunity. So, so the typical schema is that some people will follow through with treatment, but now we know only about 10% of the patients who need to be treated are actually in treatment. So many of our patients die without that opportunity. I call this a retrospective insurance autopsy, meaning that if we were to do an analysis of each one of the overdose deaths, we could determine where those missed opportunities were and correct them. And that's what we want to do going forward. So I'm going to end with the fact that we know the impact that telehealth has had on COVID and our ability to continue to treat patients for many causes, but those opportunities are being pressured by some of the insurance companies to wind the clock back, and we can't let that happen. This is a meeting that I had with Congressman Elijah Cummings just 3 months before his untimely death in Baltimore. And one of the things that he told us is, I love research, but not research that sits on the shelf. We have the information. You have the information. Now we have to make people implement that information. And in summary, we know that medical treatment works. We shouldn't be locking our family members and patients up. We need to increase the understanding of harm reduction. And I think we'll hear that later on today. Increase provider capacity, because we just don't have enough providers to serve our population. And we need patient-centered care. And of course, we need to keep telehealth in perpetuity. And thank you so much.
All right. Thank you, Dr. Chapman, for that wonderful presentation and the wealth of information that you were able to provide for us. I didn't mention, but I have some of my students in the sensation and perception class, as well as my intro class, and they've heard a lot about the agonist, antagonist, and some of the ways that they can inhibit some of those effects that we have naturally. So I definitely am thankful that you were able to give them that information during class. So We do have some questions. I forgot to mention that we are giving our presenters some time to present the information that they have, and then we're giving about 5 minutes of questions. So we do have some questions that have been brought up for us to ask our presenters first. So we're going to start with Dr. Chapman and his questions. And we can have time for questions a little bit later after all the presenters, but we just have these lists of questions that we want to ask first. So Dr. Chapman, how can people access your service or contact you?
My office is right in the center of the District of Columbia. I'm at 1647 Benning Road Northeast, across from Hechinger Mall. They simply, all they have to do is call and make an appointment. We'll be glad to see them. There are also multiple sites of entry around the city. You can call the Department of Behavioral Health. You can call any of the federally qualified health centers now have access to medication-assisted treatment in the form of buprenorphine. There are 3 methadone clinics in the District of Columbia. One at 2112 F Street. There's one at the old DC General Hospital. And there's also a 3rd methadone clinic on Good Hope Road, Southeast. Methadone clinics are more restrictive because of the federal licensing and certification, but we do have 3 methadone clinics that serve about 1,500 to 2,000 patients in the district.
All right, great, thank you. The next question, how can the workforce or employers support treatment and recovery?
So that's a tough question. It really entails education. And unfortunately, you know, in our economic system, there's not always a lot of compassion for patients who are suffering. That's one of the things that we have to educate the community on, is the fact that we need mental health and parity. And that's actually a part of the Affordable Care Act, is parity in treatment. That has to be really enforced by local regulators and state regulators. And they're across the country been very lax in enforcing those standards. So again, we need to look at the laws. We need to talk to lawyers to see that folks with a mental health or substance abuse problem are treated no differently than someone who, let's say, is off from work because they had a hypertensive crisis or a diabetic crisis. That needs to be looked into.
Great, thank you for that. And it can be difficult looking at the economics of the workforce and systematic policies that we have as well. So thank you for that information. Do we have, I want to open up for at least one question from the audience right now. You can raise your hand or put your question in the chat. Okay, let's see, second page. All right, well, we'll come back to questions, but I do want to get to our next presenter. All right. So next we have Mark Robinson. He is from Family and Medical Counseling Services. So if you can you go ahead and start your presentation, give us some great information.
Yes, good evening, everyone. My name is Mark Robinson, and I am the Regional Syringe Service Program Coordinator with Family and Medical Counseling Service. And I want to thank you, Dr. Hill, and certainly thank Dr. Chapman and Dr. Green and all of you as colleagues for inviting Family and Medical Counseling Service to be a part of this team and a part of this alliance. It's absolutely essential that we have these kinds of conversations which address some of the hard questions and begin to present some solutions as to how we can help heal our community. And it's not like there's a blanket healing going on. It's one individual at a time, one life at a time. And Dr. Chapman, I really, it's an honor to be in your company. I am eating from your table. Thank you very much for your presentation. You covered a lot of information, and you just had the sparks going off in my brain. And it's very interesting when you said that we are under the auspices of bad science. For over 60 years, you mentioned bad science. And it's certainly my belief that what we're seeing and witnessing in our community is the outcome of that bad science. And so I really appreciate your addressing some real plausible solutions. And Family Medical Counseling Service is a federally qualified health center, and we do engage in some of those solution-based strategies to help address people where they are that are under the diagnosis of having opioid use disorder and also mental health disorders, as well as needing primary health care. And we've been in the community since 1976 and have a long-standing record of doing exactly what we're now termed and mentioned as harm reduction, which would simply stated is just meeting people where they are and meeting them and servicing them without judgment or stigma, and creating a portal by which they can access these services that we're talking about to address their needs. And as it was so clearly stated on the video, the individuals that had been suffering from the ravages of substance use disorder and the perils of those lifestyles that come along with it, it's imperative that that we be there. And the teams that I coordinate on a day-to-day basis are we're in the trenches. We're in those places. We're in those so-called hot spots throughout Washington, D.C., all of the high drug trafficking areas where people are actively using opioid-based substances. And what I find very interesting and found very interesting, and I have a whole host of statistics that I can state, and these numbers are very important. But there was one number that really jumped out at me personally, and I don't know if anyone else is impacted by this number, but I read where it was said 1 in 3 Black male babies are expected to go to prison in this 21st century, 1 in 3. And when I have an 8-year-old son, so it's personal. It's personal in that respect. And then when you mentioned the prison industrial complex, and it also spawned the thought of thinking about, well, who's profiting? Who's profiting from the ravages of these disorders that we're witnessing within our community? And because profit is what's left after the exchange is taking place. After the transaction is done, that's how we measure profit. And it's clear that our community is definitely not benefiting from the transaction that's taking place. In fact, we're at a deficit, and we've been at a deficit. And I think that the pandemic has really exposed the depth of the deficit that we're witnessing. One thing that was really amazing to me, as smart as we are, as scientific as we are, as well trained as we are, as industrious as we are as a country, as all of the technology that we have. And Dr. Chapman, you alluded to all of this in stating the fact that, you could go on any corner, right outside our offices on MLK Avenue Southeast, Good Hope Road, Malcolm X Avenue, a few other spots throughout the city. You couldn't get bottled water during the pandemic. Couldn't get distilled water. You couldn't get spring water, but you could get a bag of fentanyl. You could get a bag of heroin. You can get K2. You could get cigarettes. You can get beer. You can get alcohol products. You can get all of these products, but you couldn't get paper products. In some of these communities, you can't buy a nutritious meal, but you can get some meals that are high in fat content and high in cholesterol. And I know this is kind of off the subject as it relates to opioid use, but it speaks to some of the other underpinnings and social determinants that lead us to the condition that we're in. So when you talk about wraparound, I think collectively, everyone has a role and a part that they can play and get involved in addressing this issue beyond a shadow of a doubt. And the people that need the most help, even as we conduct this panel and have this discussion, are not on the panel. They're not getting this firsthand information. So it's my responsibility to take what I'm learning here and transfer it into the community to that person who may not even be able to tell me what their problem is. They just come up to me and say, well, I need a sterile syringe. I want to exchange syringes. So what we do is we're on the front line and we're engaging with the population face to face, and we're having a conversation. We're having a conversation. We're listening. That's one of the key elements in building trust with a group of people that is very distrustful and operate in a silo because they have been stigmatized because of the behavior. And a lot of it is structural. It's not so much behavior. The stigma comes from the structure that we find ourselves in, but nevertheless, it's there, and people feel the distance. So we try to etch away at that piece by listening and meeting people where they are and having the conversation and going into those places that's not really comfortable to go into. And people generally don't look like, sound like, smell like, certainly don't feel like all of us are probably looking, sounding, and feeling and smelling, even as I speak this afternoon. So proximity is a very important tentacle of our outreach effort. We have to get close to the problem or the perceived problem, because you see things when you're up close and personal that you don't see far away. It's easy to assess and judge and think I know something about someone when I'm looking at it from a distance, but until I get up close and personal, then I can really see what's going on and I can hear what's going on, and I get an opportunity to listen to this person's what they have to say. And generally, it's been our experience that we hear where people are. And as Dr. Chapman clearly said, the criminal justice element, being physically challenged, being mentally challenged, having other conditions over their head that prevents them from being as forthright as they may normally be because of fear, the trauma that individuals are often dealing with, and also being physically ill from withdrawals. But we meet people where they are. So, it's oftentimes very uncomfortable. But the team is designed to get up close and personal. And one thing COVID did was it put a barrier in between our ability to get absolutely close because of the social distancing needed. So we had to find a way to engineer around that piece and still service folk. And the good news was, because we had a history of providing services, people recognize us and trust us and still were willing to work and come out and do what was required in order to change and receive sterile using tools as opposed to using and sharing used syringes. And that's very, very important to reduce and minimize the spread of infection and other bloodborne pathogens that result from using used syringes. And the other piece is changing the narrative. You know, that narrative that is associated with the stigma of those negative perceptions that we have of our people who are in these conditions has to change. So the language has to change. So the perception can change. So they're no longer, so people are no longer invisible because they don't look like me, sound like me, articulate like me. I pass them by as if they didn't exist until something happens. And so everyone isn't necessarily prepared to do that, but it's very important as professionals and as service providers and people that are in this field to examine the narrative. The way we talk about and think about people that are suffering from opioid use disorder. The other piece that I think has been very instrumental in us providing service and engaging with what is termed often a challenging population is the hope. You know, the hope. And I know I'm preaching to the choir when I say this, because most of the people that I'm aligned with on these platforms and listening to me, this isn't a business or a field that you get into just because. There has to be something else that drives, for me, there was something else that drove me to this. And it was personal experience, it was the conditions, it was the overcoming of various challenges. It was these same barriers that were presented to me that someone helped me with, that gave me the hope. So I'm responsible for orchestrating and defining a construct that will allow that same hope to be communicated to the people that are still suffering. I'm obligated and committed to doing that and providing people with a realistic expectation that something good can happen for them. And we do that by showing up. We do that by engaging. We do that by connecting. We do that by providing people with access. There's no wrong door. By allowing people to come in. And that's exactly what we do. And the consistency, you know, being able to depend on us being there. All of that contributes to the hope. And then the last piece I would like to offer is the willingness to do that uncomfortable stretch. You know, in this area of service, it often requires going the extra mile. People just don't come packaged in nice, neat bows with all their ducks in a row. I remember there was a situation where a gentleman was physically detoxing, and you know he was too physically sick to really navigate through the assessment process to allow him to engage with medical assistant treatment. And this was an older gentleman, and it required me like bridging the gap between himself and the person doing the assessment. And the bottom line was this man who had, you know, been chemically addicted and in and out of active addiction and in and out of the system for years said to me, he cried, he literally cried and said, you know, this is the first time someone really helped me. And I'm sure Dr. Chapman and others have had these kinds of personal experiences dealing with individuals who you're servicing. But it just further reinforces to me how essential it is to be able to go the extra mile, because sometimes you can get into a comfort zone a comfort zone and if it doesn't meet within a certain time frame and having an agenda and needing to have a things to do list and forget about the person who's on the other side of this desk or who's on the other side of this service who is being handed the syringe. If I over the past fiscal year have distributed over, and this is and I'm ballparking this figure, but it's well over this factually, over 100,000 syringes. One syringe represents one person. And I don't see numbers, I see people, people's lives. And as Dr. Chapman so clearly stated, we can't treat a person who isn't alive. So we can't assess the value of the life before we save the life. And saving the life may mean putting a sterile syringe in that person's hand. Saving the life may mean equipping them with the overdose prevention and education and giving them Narcan so that they can use on a partner or a colleague or whomever they're using with who may overdose. You know, it may move them along that track of the stages of change to the point where they're ready to do something different. And that's the goal, to move people along that track. And everyone isn't willing to move, and we can't make people move, but we certainly have to be present and accounted for and provide the best services as if it was someone that I love dearly and was personal. Like I said in the beginning, 1 in 3 Black male babies are expected to go to prison in the 21st century. And so it's personal in that regard. So you know, I keep those kind of things in my mind in providing and presenting and talking with people, because the problem is certainly pervasive. But we're very smart people. We are very smart people, and we have a will. And it's evident in the work that's been done. I stand on the shoulders of some great minds and some great intellects and some people who have pioneered in these fields and doing and servicing our communities. And it is a community disease. It's plaguing the community. And we aren't the people that are profiting from the transaction. And in order to turn it, I believe that, as Dr. Chapman said, these alliances that we're forming, this wraparound service has to be able to meet people where they are. And the alliance has to be cohesive and comprehensive. And I guess there's some other structural things that need to be done as well that I guess this panel and other people on this call will get to discussing. But my contact information, I believe Dr. Green has all of our contact information. We're located at 2041 Martin Luther King Jr. Avenue on the 3rd floor. And you can do walk-in appointments if you can access us through the website, www.fmcsinc.org. I can be reached at 202-699-1984. That's my direct cell phone number. If you know someone who is in need of Narcan, or if you know someone is in need of training as to how to use Narcan, I have a team of people that are able to provide that sort of training. We are a distributor of Narcan at Family Medical Counseling Service. We operate on both sides of the border. We're also in Prince George's County, providing the same level of care as well in the Seat Pleasant area, 5936 Martin Luther King Jr. Highway at Seat Pleasant, Maryland. So thank you all for listening. I hope that something I've discussed or said will be helpful in helping someone further commit to the work that we're all committed to doing. I'm excited. It's a pleasure to be here. It's a pleasure to be involved. It's a pleasure to be asked. What I know personally is that there's no human explanation. You know, this in my humble opinion is God's work, and it don't get no better than this when we're serving. So I implore you to continue to serve in whatever capacity you're able to serve. Help somebody. Help somebody. It makes a difference. Thank you all for listening.
Great. Thank you, Mr. Robinson. We appreciate that. And it really hits home when you start to talk about the families and communities that are just trying to find those basic needs, right? We want to make sure that we're taking care of those basic needs so that we can look at a more holistic way of looking at treatment and recovery as well. And as a developmental psychologist, I always think of the development of our children into adults and wondering if they have those basic needs that they need, or else they're going to go find some other way to fulfill those needs. So I definitely appreciate you speaking to that, as well as talking about your real life experiences with seeing some of these members of the community and dealing with some of these addictions and how to actually ask or being ready to ask for treatment. So I definitely want you to answer a few questions if you can. One of those questions is, how do we remove the stigma from opioid use or abuse in our communities?
I think part of it begins with, first of all, us educating ourselves as to what a stigma is and where it comes from. First place. The second thing would be to understanding that the substance use generally is a symptom to an issue or dilemma or disorder that probably has not been addressed or maybe undiagnosed. And, you know, we have a tendency to put people in categories, and we codify and classify people in all kinds of ways. And in doing that, it thrusts upon those people this negative perception based on behavior. But we need to educate ourselves. We need to really educate ourselves and dispel some of these distortions that we carry concerning people, because the bottom line is, you know, you never know how the table can turn. You know, we a lot of times I think we see ourselves as being insulated from some of the ills of the people that are suffering from some of these things. But we never know that one thing, and you're a psychiatrist, so you understand that there's one thing, the wrong thought going through my brain at the wrong time can cause me to come unraveled. And the table can easily change. But I think to develop that kind of empathy requires us really looking deep inside ourselves to dispel those distortions about stigma.
Great.
And where those stigmas really come from.
Thank you. Thank you for that. And the other question, I want you to think maybe back to a time where you did see that young man, or you saw a young woman, and they said, you know, I don't know if I'm ready for a treatment. You know, what would you do in that case to help them with that and help them to prepare for treatment, or to kind of pull them in that direction for treatment?
My first line of defense would be to try to keep them safe where they are. And that would mean, you know, equipping them with what they need that was in our arsenal to be able to provide. That's the first thing, because it's important to build a trust, and to build that relationship requires direct engagement. So I'm going to listen. You know, I'm going to ask some questions. Well, what are you ready for? What would you like to do? What is it you would like to do? How can I help you? And you know, when you begin to engage after you listen to a person, you begin to ask certain questions, it begins to provoke thought. And one thing that I've learned, there's no such thing as a stupid, if I can use that word, stupid, chemically addicted person. People with opioid use disorders are highly intelligent, highly ingenious. You know, they're very ingenious. especially when you talk about street level folk, people that are operating in the street, that are surviving in the street. Because you wake up with nothing and you have to get to something within a certain window of time. That takes a certain amount of ingenuity. So what I need to know is, how can I help you? How can I help? And I'm going to listen very intently to understand what I can do to help. I'm not trying to enable, but I'm trying to help. And so if they come in my purview, you know, if you come in, if you come in the door, I'm gonna give you something. So I'm going, you know, you can count the number of seeds in an apple, but you can't count the number of apples in the seed. So I'm gonna plant the seed. That's what I'm going to do. I'm going to plant the seed, and I'm going to plant it deep, and I'm just going to wait, because, you know, that's what I do. I'm a seed planter. You know, in order to make something grow, you got to put your hands in the dirt.
Right.
I'm not associating my people with dirt, but I'm saying you got to get dirty. You got to get in. You can't stay back. So I hope that answered the question. That's what I'm going to do.
Sounds like that tunnel vision. It's like you see it and then you go find that person. So it's, you know, if somebody needs help, you can see the signs. You have to see the signs and symptoms there when anybody needs help. Awesome.
And then also, Dr. Hill, you know, when a person needs help and they know you're genuine. And one of my colleagues who's on this call, he says, you know, people don't care how much you know, so they know how much you care. He says that all the time. And when they know, when they can feel that there's a genuine concern about them, they open up. People open up. And that's a key point.
And I wanted to bring in Dr. Chapman on this as well. I was reading something from one of your bios, and it talked about how you believe that it takes a village, right? That you believe that the community, everyone needs to be supportive of this person who is seeking treatment or who may need treatment. So what would you say to that for somebody who may not be ready for treatment, but they're seeking treatment?
So I gave you the toned down version of my presentation today. But I actually gave a similar talk about 4 weeks ago at Howard to the School of Pharmacy. And I used the slide that came from a chance meeting of Flavor Flav in Nassau about a month ago. And I went back and looked at the lyrics of Fight the Power. And in the very first lines of the intro, it says, "Yet our best trained, best educated, best equipped, best prepared, refuse to fight. Matter of fact, it's safe to say they would rather switch than fight." And when you think about how profound that statement was, it means that we've been programmed to dismiss our history, our 402 years of history. So if you have amnesia about our history, then you've been programmed to do what somebody else wants you to do under their perception of history. So they're basically telling you, forget what happened to you for the past 402 years, and look at you now. Look what you're doing. You were destined to be in the gutter. If you believe that, then the people that believe that, and what they're saying is, if you're so educated, how could you not see through this fog? So I was fortunate enough to have come through Howard at a time when Nathan Hare was my instructor in sociology, second semester. I can remember him standing there, and he's now considered the father of Black studies. He actually helped shut down the university in 1967, and he got fired. He went on to California and got a PhD in sociology and psychology. But there are people who will sacrifice themselves because they were just that far ahead of the curve to understand what was being done to us. Our patients are taking opioids to treat pain, but it's not physical pain. It's emotional pain that they're treating. And about 3 years ago, Dr. Ayanna Jordan at Yale, Black psychiatrist, published a paper, and in that paper basically said what we've seen over and over again. If you talk to our patients, most of our patients started with street drugs. They started with heroin. They started with cocaine. They started with PCP, but they were not treating physical pain. They were treating emotional pain. And then when you dig into those histories and show them that they were treating pain, they were treating emotional pain, you will find that there was trauma in their childhood. And now we talk about adverse childhood experiences, adverse community environments. We're seeing that every day with the shootings in our community. How traumatic that is growing up in that environment. What does that do to your synapses in your brain when you can't sleep because you're worried about getting hit by a stray bullet? If you think back to Ron Clark and rap, he understood that there was a disconnect between our community and our history, and that's why he developed the Afrocentric approach to treatment. Because once you can connect a person with their history and understanding that something happened to you, you're not the problem. The environment is the problem. And once we touch that in the individual, we can begin the process of healing. That's why I say over and over again, we do this as a team. We do this as a village because the peer support workers have been places that I haven't been. They've seen things that I don't know about. And so when they bring that to the forefront in a patient, they're able to better connect with that situation that I am. The social workers connect with the patients when they understand that this person needs housing. They don't need a whole lot of talk. They need a roof over their head. They need a safe place like anybody else. And of course, our psychologists and psychiatrists. So I think it's really connecting with our history as a community and our history as individuals. Once we make that connection and understand that it's this environment, is what you saw on January 6th, that's sick, not us. You saw it on January 6th, and you see it every day when you turn on CNN or MSNBC, and these folks telling you that you didn't see what you saw. That's called cognitive dissonance. That means that's the same thing that Kellyanne Conway said that when she talked about alternative truths. There are no alternative truths. There's the truth. And what we're seeing is the fact when we turn one of our brothers around who's been to jail 4 or 5 times or 10 years or did this and did that and show a completely different side of them, you are proving the lie that we've been told all these years. So I think Mr. Robinson will agree with me that that's what we see every day. We're able to, as they say, truth beaten to the ground will rise again.
All right, thank you. And one final question for Mr. Robinson before we open it up for the audience. How do you think the workforce or employers can offer help to those who are seeking treatment and who are opioid users?
The workforce can assist individuals who are opioid users by addressing some of the policies and directives that are in place within certain organizations and within their structures. Their policies need to reflect that they're treating this as a medical issue, as opposed to dealing with it from a punitive perspective. I think that's one of the first things structurally that can be done.
All right, awesome. Thank you for that advice. Definitely, for those who may have friends or family members that are dealing with this and trying to figure out how to get help, or employers or the workforce who are looking for ways in order to assist their employees or to build that workforce. So I want to open it up now to the audience for any questions. You can put questions in the chat, or you can raise your hand using the icons down at the bottom of the reactions. Let's see.
This is a quiet group, Dr. Hill.
I see. Maybe they just got so much information that, you know, they don't really have any questions. That's awesome. Our presenters, our panelists did a wonderful job at giving us some information.
It's marinating.
Yeah, exactly.
Whenever you have Dr. Chapman and Brother Robinson Mark on, you know it's going to be hot, right? Yeah. But these are actual resources. These are individuals. They're in the community. They're doing the work. And, you know, it's probably over 100 years of history just between the two of them talking about the work, not just on opioid, but just on what we see in our community. And to have Dr. Chapman quote, you know, public enemy. I mean, go ahead, Doc.
Yeah, take us back.
Okay, so, you know, woke folks on here.
Right.
And I appreciate, because what Mark and his team does, and by the way, they partnered with one of our sub-grantees at a hotspot on Pennsylvania and Minnesota. And just before Mr. Perry was getting up to do his presentation, he had to pause and take care and save a life with Narcan. So what we're doing right now, even, you know, having these conversations, our folks are in the community doing and literally saving lives. And every second and every effort matters. And even when people are not ready yet, right? My dad is in recovery. I said 30, but it's 29 years in December. And he's going through a lot. You know, he got his car jacked a week ago, and I was like, oh my goodness, what is about to go down? And, you know, life happens, and he's, you know, he said, as soon as I get my car, I'm going back to my meetings. He said, because I'm about to, you know, so these things are real. People feel them, but the effort to stay in the moment and to remain, to be part of that recovery community is very important. That sisterhood, that brotherhood, that community, that village that Dr. Chapman always speaks of matters. And we do prevention, but you can't exclude the role of prevention, the role of treatment, and the role of recovery. They're not silos. They work hand in hand, because at any point in time, we're in different portions of that, but it's happening as a collective. So, that's my 2 cents. I appreciate them. I'm not sure if there's anybody on from Oxford houses, because I want to make sure that what Dr. Chapman spoke of was the housing instability for populations that are in need. Housing instability is a right. It's like having fresh drinking water. We really need it. And having unstable housing, being homeless, that is a very scary thing. And my family experienced homelessness several times. And so we really need to have places where people who are in recovery, coming into recovery, have a place to live and be around individuals that are also doing recovery. And Oxford houses are international. We have several throughout Wards 7 and 8 and throughout the city and throughout this area. But these
35.
are homes that
Yeah,
are
35
self-supporting.
of them.
Yeah, 5 of them. Yeah,
35
35
in DC. Mhm.
in DC. So, each of them are self-run homes. So the individuals that live in these homes are substance-free. They agree to that, but they're self-supportive. So everybody has a rent that they pay a portion. It's just like living in your own house. You got to do your work and everybody collects and does it as a collective. But if you haven't had that kind of stability for a while, these places and spaces provide that for you. And you're not separated from your family members, because we also know that part of recovery is really having a supportive family that helps you along that way. And I recall one time we were at my oldest brother's birthday celebration, and the punch was lit, and my dad had it, and we're all enjoying it, and nobody really thought, oh, smack. No, so he tasted it and he was like, okay, guys, thank you very much, I'm out. And it was just me, was like, oh, why did we do that? Not thinking, but being very conscious sometimes. So not to make someone feel stigmatized by this, because we're all affected by it, is really important. So I really appreciate the work that Dr. Chapman does every day, the work that Mark and his team does every day, and really, really on the ground, foot soldiers in addressing not just this crisis, but multi-pronged areas that are impacted by substance misuse. And so I thank you guys so much. And there you are, Mr. Perry. That's the hero right there, you guys. Life-saving hero, for sure. So
And Mark has his hand up, Nora. Mark has his hand up, but thank you for sharing that. That's very, very important.
I had a question for Dr. Chapman, because we were talking about resources and the need for providers. And I guess my question, Dr. Chapman, is how do you think we can move the dial as it relates to funding to increase the flow of dollars that could help us do a more stellar job at what we're already doing, as opposed to always having to make a dollar out of 15 cents? What can we do to move that dial?
I'm glad you asked that question. There was a study done maybe 20 years ago, maybe more than that, to show that every $1 spent on substance abuse treatment saves $7. I participated with the Georgetown Law School litigation summit this past Friday. And I showed a series of slides that showed, in effect, how I'm going to use the term defund the police, but the way you defund the police is treat people. And to treat people, you have to have housing, you have to have medication, but first of all, you have to be able to reach that person. And so there are people that we've already talked about. Peer support is critical. If you take one person off the street, and I've had that to happen. I had a patient that got lost to follow up back in December. My peer navigator reached out to that person, got him back in treatment. And the amount of money, just think about it. He was no longer buying drugs on the street, which with a $50 a day habit, you need about $150, so they tell me, to supply a $50 a day habit. That comes to about $50,000 a year. If you go to jail, it costs $35,000. So just by getting him off the street, he no longer had to do what he had to do. His chances of getting pneumonia or getting AIDS or getting hepatitis C dropped dramatically. So when you add all that up, there's savings outside of medical savings. There's social service savings. If you're a parent and you have children, instead of those children going to family court and foster care, that costs the government money. So what I'm talking about are so-called wrong pocket savings. Now, the problem with wrong pocket savings is that the insurance companies don't accrue any benefit from that. The only thing they look at is their bottom line. So they look for reasons not to treat. And their reasons for not treating were all of those barriers that I showed in one of those first few slides. They put up roadblocks, and those roadblocks that they put up really go back to just what you said early on. You can go out on the street and find fentanyl faster than you can find buprenorphine. I got $100 on the table that you'll be able to find somebody selling fentanyl before you find somebody on the street selling buprenorphine. But the government and the health insurance companies treat buprenorphine as if it's more powerful and more dangerous than fentanyl. What kind of sense does that make? It shows that we have a structural and a perception that makes absolutely no sense. And the fact that we're now able to talk about that, we can now force the government to pay for peer support services, just as they pay for a patient coming to my office to see me. You need to pay for the social worker, just as you pay for services when you go to the doctor's office. Those are services that right now are not under the typical E&M codes or evaluation and management codes that Medicare and Medicaid pay for. But if they were, if you paid for all the services that are required to treat this patient population, I can give you a paper from the Federal Register that came out on November the 2nd of last year that shows that it costs $42,000 not to treat. It costs $7,500 for all of those services that I just described to treat. That's a $35,000 savings per patient. Now you tell me where that money is going or why we're not seeing that money. It's being penny wise and pound foolish. If you spend that money up front and pay for those services, you will accrue the so-called wrong pocket savings on the back end, which means that criminal activity and the first slides that I showed in Europe will go down, that infections will go down, all of the things that we're talking about, all the good things will happen. But you have to force the government to spend the money up front. And those savings don't stop in 1 year, they go for a lifetime.
All right, thank you, Dr. Chapman, for sharing that with us. We are going to do the exit survey soon, but we want to hear a word from Dean Smith from the Workforce Development and Lifelong Learning Campus. So Dean Smith, would you like to say some words to close us out?
Hello, everyone. Can you hear me?
Yes.
Okay, I just want to say welcome to everyone, all the presenters and attendees. Thank you so much for a riveting presentation with passion and conviction. I am in and out, so I haven't been able to attend the entire meeting today, but from what I've heard, you know, you guys are, you're right in every way. I can only just say ditto. You know, so not to, you know, go too into depth, but my background in prevention science also just demonstrates so much that we have to look at, particularly the cultural, the social, the emotional, the physical. There are so many aspects of every human being's lives that are impacted by their mental health, and that's also impacted by the behaviors that are elicited by people. And, you know, it's a huge subject, and our job is to only take one step at a time. And like they said, everyone has said, you know, your job, all of our job, including me, is to continue to communicate, to share this information, to pass it along, and to get people to come and attend events like this so that they can learn. They also can fellowship and receive the support that they need as well, without stigmatization, labeling, and all those things. So I don't want to get on my soapbox. I want to say thank you to everyone, particularly the presenters. Wonderful job. I've learned, I'm inspired, and I'm looking forward to us continuing to bring together like minds and hearts to address and to support, particularly our DC residents. Thank you all.
Thank you, Dean Smith. Nora, would you, well, I guess I can direct them to the chat where the exit survey link can be found. Make sure that you all complete that survey. It is so that we can know who was here and get some information about what are the needs of the community or at UDC. So please make sure that you look at that link in the chat section and you can click on it to complete it before you leave out. Dr. Greenlane, would you like to close us out?
I think what I talked a little bit too much earlier, so I'll let Roz, if you'd like to kind of wrap this all up for us in a nice bow. And I also wanted to recognize my other colleagues that have been on the line, Stephen Hazel, Brandon Bridgers, and Dr. Lauren Ramsey from the Wards7&8 DC Prevention Center are also on the line as well.
Excellent, excellent. And I know there have been some questions in the chat. So I put a new website link for Federal City Recovery that I'm looking at on my phone. I'm actually on their website. So yeah, that link should work. And then there was a question about, with excellent question, about resources for children whose parents have died from an opioid overdose. I made a quick call to our other former colleague, Dr. Orlando Barker, who's going to be with us tomorrow, who works at DBH, and he helped me focus on two resources: Total Family Care. You can Google their information, Total Family Care, and also FAN. And it was too long to type out what FAN stands for, but their website I put in the chat. Okay, so answering just those questions that I saw real quick in the chat. This has been another day of a very powerful and fruitful discussion across the whole range of areas. And we really appreciate everyone's time. And hopefully you all can join us tomorrow as we close out. We have two things coming up. We have a Narcan training, as Mark alluded to, very important. And I know Dr. Chapman agrees with this as well, to have more people know how to use Narcan and to have Narcan in people's hands. And so at 12 o'clock, we are doing a Narcan training. If Nora, if you could put that flyer back in the chat, please. And it's at 12 o'clock. And then Once again, at 4 o'clock, as we close out this conference, or this, it feels like a conference, workshop series, that given the powerful speakers we've had, definitely quality of a conference, workshop series tomorrow at 4 o'clock, where we are going to further discuss Department of Behavioral Health as well as UDC resources around prevention, recovery, and treatment resources that are available at Department of Behavioral Health as well as at UDC, primarily through the counseling center and other services that are on campus. So we look forward to that discussion as well. And again, thank you all. We have been ending each day a little early, so that gives you all some time back if there are no additional closing comments or questions. And we'll give people time to close out the survey. I am going to.
And Roz, can I thank our wonderful moderator, Dr. Hill?
Oh, yes, I'm sorry.
You did a
Yes.
fantastic job,
Yes,
Dr. Hill. We really
yes.
appreciate you. Thank you so
Exactly.
much.
Thank you.
She's the
Yes.
link for us, you guys.
Exactly. And on that note, I'm actually going to stop the recording as we do thank Dr. Hill. Thank you so much. It's wonderful to